Good afternoon. Thank you for attending this month's Ocean Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to welcome Dr. Arvin Garg of the University of Massachusetts Chan Medical School and UMass Memorial Health as he presents on lessons learned from the pandemic that can be applied to advancing child health equity. Dr. Arvin Garg is a professor of pediatrics and vice chair of health equity at University of Massachusetts Chan Medical School and UMass Memorial Children's Medical Center. He is also the Associate Chief Quality Officer for Health Equity for the UMass Memorial Health System. He is the founding director of the Child Health Equity Center at UMass Chan and UMass Memorial Children's Medical Center, and he is also the program director for the Child Health Equity, also known as PATH Fellowship. He received his BA in Behavioral Biology from Johns Hopkins University, MPH from Boston University School of Public Health, and his medical doctorate from Boston University School of Medicine. After completing his clinical residency in pediatrics at the University of Connecticut, he worked for 2 years in private practice in Pennsylvania and then subsequently completed a postdoctoral general academic pediatric fellowship at Johns Hopkins University School of Medicine. Dr. Garg's research focuses on addressing adverse social determinants of health within the delivery of pediatric care, particularly for low-income families, and has been cited in professional guidelines, and he has published over 100 publications in such places as, to name a few, Pediatrics, Academic Pediatrics, Journal of the American Medical Association, and Journal of Asthma. Since 2009, Dr. Garg has been continuously funded by the NIH and has also received extramural funding from private foundations. This session is being recorded. Attendees are muted upon entry, so please pose your questions through the Q&A or chat box. This presentation will last approximately 40 to 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Arvin Garg for Advancing Child Health Equity, Lessons from the Pandemic. Dr. Garg, the floor is yours.
Thank you, William. Thanks for that kind and overly generous introduction. I really appreciate it. Let me start sharing my slides. It's really an honor to be here with you all here virtually. With Ocean Group, I've had so much admiration for the work you all do on a daily basis to really advance health equity for the most marginalized populations we serve in the country and in our society. So thank you for all you do, and thanks for being here today. So I'm going to just minimize these pictures here. I have no financial relationships to disclose. I do want to disclose one thing given the subject matter. And I'm going to be talking a lot about poverty, and I've never lived in poverty. This is a picture of me with my parents after I graduated from medical school. So I grew up in a suburb outside of Boston. I was born in Boston. My parents immigrated about a year before I was born, and had a pretty blissful suburban life, childhood. And I haven't gone that far in life. I literally lived 2 towns over from where I grew up, another suburb of Boston called Newton. These are my 2 daughters who are huge Boston sports fans. I should probably replace these pictures with Celtics scarves, since it's been a rough couple of years for the Patriots. But it's one of the proudest things I have is having my daughters being such Boston sports fans, like I was as a kid myself. But my parents left India for the American dream. So this is the first picture of my parents. This first picture is my parents being dropped off at the airport from their extended family as they came to America. My mom decided to get her master's degree here at Ohio State University. And after a stint in England and back to India, they decided to settle outside of Boston, where I was born. And although I didn't grow up in poverty, my dad did. He was a master storyteller and told me about how he grew up in the Depression under colonized rule by the British, lived in an overcrowded room with too many siblings and cousins to count, often only having a meal a day, and made him determined to leave those circumstances by pursuing higher education for himself and for my mom. And they ultimately ended up both with PhDs. And it was quite poignant for me to have a meal at my dad's house after he passed away with my own family, with my wife and my daughters here. And although I didn't live in poverty, I witnessed abject poverty when I was a child visiting India, visiting my grandparents, uncles, aunts, and cousins, seeing people who looked like me, who were poor, in such completely different circumstances in which I grew up in my childhood. And it was just really hard to ignore. And I didn't really realize it, but it really left an indelible impression on me that continues to inspire the work that I do now. So it's a picture of me in a rickshaw. I'm not really sure why my parents left me in the rickshaw like that by myself. I didn't really know the language, but maybe for the photo op. But these experiences have, I think, subconsciously led me to work with low-income minoritized populations and do the work I do to honor my ancestors. So I just wanted to share that disclosure as I move forward in this talk. So learning objectives are to explain the drivers of health inequity for children, to explain poverty's detrimental impact on children's health and development, and to propose some potential paths to advancing child health equity. And although we're trying to put COVID in the rearview mirror, this invisible, pesky, lethal virus exposed us to the persistent health and healthcare inequities in our society. The COVID-19 pandemic has led to over 1 million deaths in the United States and led to over 250,000 children being orphaned in the US. And as we face that same storm, the same COVID-19 storm, it demonstrates to us in our society that we're not all in the same boat. And this is an analogy I've taken from Dr. David Williams, professor of public health at the chair of Department of Social and Behavioral Sciences at Harvard T.H. Chan School of Public Health. So even though we face a pandemic, the same pandemic, there were great disparities, great inequities in who got COVID and who ultimately died from COVID. And although the focus for COVID was primarily on adults, and probably rightly so, COVID-19 had its detrimental impact on children. That is, children were not immune to the virus or the disparities that stemmed from it. And this is a study that first came out when COVID came out. So in May of 2020 from Dr. Monica Goyle at DC Children's. And she reported, this is at a testing station in DC, and she found that low-income children had higher odds, 38 to 9%, compared to 9% for high-income children for testing positive for COVID. So twice the odds of testing for COVID than higher-income children. And that Hispanic Black children had almost twice the odds of testing positive than white children, between 30 to 46% compared to 7% for white children. And thankfully, not a significant amount of children died from COVID, but over 1,500 children did die from COVID over 2 years. And Black children were almost 3 times more likely to die from COVID than white children. And overall, over 120,000 American children became orphans. That is, they lost a parent or a caregiver to COVID-19. And there are wide racial disparities and inequities in children who were orphaned during the pandemic. And this really brought home the importance of what our public health colleagues have been telling us for generations about taking an anti-health and equity approach, so really promoting health equity to counter the unfair burden of poor health. And so just to level set, health, this is a definition from the Robert Wood Johnson Foundation. It's my favorite definition of health equity. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. And so what this requires for the RWJ Foundation is it requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and a lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. I think many of us have seen this depiction of a father with his children watching a baseball game and the difference between equity and equality. This is one I found on Twitter, which I thought was a little bit more, a little bit more descriptive of what the reality is. So, in reality, in our country, many individuals get more than is needed, while others get less than is needed, and a huge disparity is thus created. Equality is the assumption that everyone benefits from the same supports, and this is considered to be equal treatment. Equity means that everyone gets the supports they need, which produces equity, and this allows, in this depiction, everyone, the children and the dad, to watch the baseball game. And justice is really the ultimate goal, that in this depiction, all three can see the game without supports or accommodations because the root cause of inequity was addressed. The systemic barrier has been removed. And so in pediatrics, we've had this, I believe, an important role in advancing equity and being advocates for equity throughout our profession, since the foundation of our profession. And it's really in our DNA for who we are and what we do. When we take care of children, either in the practices that we practice in, community health centers, private practices, you name it, whatever practice that we work in, it's hard to ignore the social milieu, the circumstances that that child lives in, and how it directly impacts that child's health and development. And so people consider Dr. Abram Jacobi the father of pediatrics. He worked at the turn of the 20th, really 19th and 20th century. And he's considered to be the father of pediatrics. And he was really motivated by issues of social justice. He fought to ensure clean water and decent housing for poor urban children. So again, since our roots, we've kind of seen this intrinsic connection between social circumstances, the social environment, and children's health and development. And so, with COVID-19, it really allowed us to think about some important lessons that we can derive from the pandemic to advance child health equity. And this is what I'm going to kind of talk about over the next few minutes during this talk. There's some really important lessons, and I try to distill some to some key ones that I think are important to talk about. All right, lesson number one: eliminating child poverty is possible. So the American Academy of Pediatrics in 2016, in their policy statement on poverty and child health, noted that poverty is a key social determinant of health and contributor to child health disparities. If you look at the poverty rates, this is official poverty rate used since really 1959. You can see that children are currently the poorest segment of the population when you look by age. Currently, about 14% of children are poor, live in impoverished conditions. And really since the 1970s, children have become the poorest segment of the population. Before that, it was the elderly in the 50s and 60s. But because of legislation on the war on poverty with legislation from Lyndon B. Johnson on Medicare and Medicaid, thankfully, the rate for elderly poverty rates went down pretty precipitously. But unfortunately, since then, since over the past 50 years or so, children constitute the poorest segment of our population. If you look at the definition of low income, so that means that income at least twice the federal poverty level, which is about $52,000 a year for a family of four to make ends meet. And there's a lot of geographical variation to that. So some places where you live versus others may be able to make those ends meet with that type of income. Others will still need a higher income. But we say we use that definition of low income. That equates to about 35% of all children living in a low income household, which is equal to over 25 million children in the United States. Simply stated, the US has the highest poverty rate compared to other developed countries. This is for all ages, but particularly for child poverty here. And the impact on child health and development from poverty is consequential. So if you grow up in poverty, children have higher rates of poor birth outcomes, higher rates of infant mortality, being born at a low birth weight. If you look at almost every measure of child health outcomes, obesity, asthma, otitis media, ear infections, poor children have higher rates. Poor children have higher rates of behavioral and developmental delays, and poor rates of finishing high school and graduating from college. And unfortunately, the effects of poverty during childhood don't escape children when they become adults. And so even for adults who grew up poor but have escaped poverty, something happens to their physiology where they still have increased risks of really common chronic conditions, including increased risk of coronary heart disease, increased risk of stroke, and earlier mortality. And there are possible life course mechanisms, the three I've reported here. So people have studied this and shown there's a cumulative exposure to stressful experiences. And for living poor conditions for children. There are multiple stressful experiences that they're experiencing on a daily basis. And this leads to a breakdown of the physiological steady state. Others have supported that there's a biological embedding disease, that these experiences, these harmful experiences, these stressful, traumatic experiences are programmed by epigenetic changes into the structure and functioning of biological systems, kind of changes the outside load that our systems, our physiology responds to. And that there are also really important sensitive time periods in early childhood and adolescence where the developing brain is receptive to environmental signals changes, which changes behavioral responses. And so there are areas in the brain that there have been MRI studies and other neurocognitive testing showing that poor children's hippocampus and temporal lobe and frontal lobe, there are physiological changes there that lead to language delays and other delays associated as well. So simply stated, poor children experience worse health across their life course from cradle to grave. And so we can learn from the experience in the UK. So in 1999, Tony Blair, who was prime minister back then, he felt that he wanted to end child poverty. He stated that no family should have to rely on food banks to be able to survive. As a country, let's recommit to eradicating child poverty within a generation. And through specific public policies, he was able to cut the child poverty rate in half. And in 2019, the National Academy of Science, Engineering, and Medicine came out with a roadmap to reducing child poverty. And policies that would reduce the poverty rate in half within 10 years. They had proposed having a child allowance of $225 a month, which I'll talk about in a few minutes, raising the minimum wage to make sure that it actually is a meaningful wage that everyone can earn, increasing the earned income tax credit payments, increasing SNAP benefits for food, and making housing vouchers directly more available to families. And so during the pandemic, as some of you may know and experience, that there was an increase in the child income tax credit. And this was part of the pandemic relief package. And so for kids less than 5, for any child less than 5, families receive $3,600 for that child, up to a max income amount, household max income amount. And for children between 6 to 17, it was $3,000 a year for that 1 year. And just, it had such a meaningful impact on families during such a stressful time period when there's high employment rates and there's such high uncertainty. And having just one child tax credit payment reduced financial anxiety for over half of families who received it. And unfortunately, as this New York Times headline reports, just as we pull children out of poverty, it's set to reverse course with a vengeance. And so because of politics, after a year of the child tax credit expansion, it wasn't enacted again by the Senate. And because of concern that the money would be spent wrongly by families and households. And so when you look at the supplemental rate of child poverty, you can see that overnight, 5 million more children experience poverty because of this policy that's no longer enacted. And there have been some efforts now to try to augment the earned income tax credit. And I think just passed legislation or passed the House at least. But it's not to the level where it was during the pandemic, and it may have raised about 500,000 to 1 million children out of poverty, but not to the level that we were at before. And so this was another commentary written from Dr. Matthew Desmond, who wrote the book Evicted. And he wrote in here, his title is America is in a disgraced class of its own. And this is what he wrote. Ending addiction to poverty. So poverty isn't just a failure of public policy. It's a failure of public virtue. To break the cycle, we must commit to becoming poverty abolitionists. Like abolition movements against slavery, abolitionism views poverty not as a routine or inevitable social ill, but as an abomination that can no longer be tolerated. And this was just, really powerful. This conversation kind of caught my eye and was really poignant. And as we think again about when we see poverty in the United States, disproportionately children are affected by poverty, and it's just short-sighted for our policies not to help families be lifted out of poverty that has long-term consequences for children, for adults, and for our society. All right, lesson number 2. It is necessary to address racism at all levels. And this came into our collective being, not only with the pandemic, seeing the racial inequities and who was getting COVID and who died from COVID, but also with the murder of George Floyd, where we had this moment, this collective moment of really thinking about, reflecting about the structural interpersonal racism that has existed and perpetuated over generations in our society. When you look at children, Black, Indigenous, and Latina children are disproportionately low income. So overall, 28% of white children live in low income households. Over 60% of Black, Latino, and Indigenous children live in low income households. So children of color disproportionately live in poverty and low income households. And when we think about just income, we think also about wealth. And this was another headline in the Boston Globe, my hometown newspaper from a few years ago. The headline is, "That was no typo. The median net worth of Black Bostonians really is $8." And when we did this study, this is from the US, from the Federal Reserve, they found that the mean household net worth for white families was about $250,000, but that for US Blacks, it was only $8 or so. And again, I kind of reflect back to my parents' experience, chasing the American dream, moving outside of Boston, and thinking about generational wealth and the importance of buying a house. My parents bought their house in the suburb of Boston for about $50,000 in the mid 1970s. But my dad also taught, and my mom also talked a lot about the experience of trying to buy a house in that town, in that affluent town, and how many families were kind to them, but kindly said no for whatever reason. But there was this one family who, my mom loved this house. It was like the house that she just fell in love with. And I think I was 2 or 3 at the time. I was running around the house, and this family kind of saw the humanity. They looked beyond the common humanity they saw in us. They looked beyond my mom wearing her sari, the accents that they had, the culture, the different cultural heritage that they had. But they saw this common humanity, and they took a chance and sold the house to my parents. And now that house in Boston or outside of Boston, is worth 30 times as much as my parents paid for. And so it's going to affect this wealth for my children and my grandchildren in a way that if this family didn't give this opportunity to my family, we wouldn't have this unexpected wealth that they never dreamed of when they bought that house in 1976. When we think about the social determinants of health, it's really looking upstream to the factors of structural racism. And structural racism is embedded in the societal, institutional, and organizational structures and interconnected policies that limit both opportunities and resources for marginalized racialized groups that manifest as social determinants of health. When we think about the racial and ethnic disparities and why are they persistent in our society, there are persistent disparities in resources and education based on one zip code, based on the persistent policies of redlining, persistent segregation that many of our cities and towns still continue to have with the housing policies and zoning policies. There are inequities with public policies related to housing, education, and the criminal justice system. And there's this ethos, right? There's this common myth of this rugged individualism in the United States, which arose support for anti-poverty programs. There's this myth that we all came here, put up our bootstraps and just worked hard, and we were able to achieve the American dream. But really, that playing field has never been equal for all parts of society in our country. And so, during the pandemic, I had to do some learning. I had to be introspective to learn about racism and learn more about it. And I'm sure many of you did the same. And I had to go outside the medical literature to learn. And so one of the books that I read was Caste by Isabel Wilkerson. It makes a powerful case about the hidden, unspoken caste system in the United States, whereby races are placed in a hierarchical order, with Black individuals in the lowest caste order. This whole caste system really resonated with me. The caste system was invented in India. It harkened to my own heritage, where the caste system is still a part of life in that country. It's still part of life in my relatives and conversations. And it's something that I'm deeply shameful of. Um, but as we think about this caste system, we think about structural racism, these health inequities and healthcare inequities continue to exist in this country, and they're actually widening. This headline really stuck out with me. And I'll probably read a couple times just to make sure it makes sense to everyone. But Black infants in America are now more than twice as likely to die as white infants, a disparity that is wider now than it was in 1850, 15 years before the end of slavery. So the infant mortality rate for Black infants is higher than it was than before the end of slavery. And this is particularly really important because since 2020, the majority of children are children of color. So we have a majority minority population of children in the United States. So, one of the great things about pediatrics is that we've made a lot of mistakes in our history, but we've also, because of our more broader view and understanding of the link between children's health with social factors, we've had these policy statements. I referenced one on child poverty earlier, but in 2019, this policy statement on the impact of racism came out on child and adolescent health. Again, pre-pandemic, this is something that our field was thinking about for a very long time. And Dr. Maria Trent, who was one of my mentors at Hopkins, was the first author on this policy statement. And so racism, in the policy statement, they say that racism is the core social determinant of health and driver of health inequity, and that there are various forms of racism: institutional, personally mediated, and internalized, and that racism has negative impacts on health and well-being, including related to birth disparities and detrimental mental health for children and adolescents. In the policy statement, they also state that the medical homes, so the primary care setting that our children go to and receive care from in pediatrics, including community health centers, that we had to take an anti-racist view, an anti-racist model of care to these children and families. That we need to ensure that it's a culturally safe medical home. We have to acknowledge racism that our patients and parents have experienced, and it's something that they experience on a daily basis, and we need to have an ability to connect with them and be able to acknowledge what they're facing as a trauma on a daily basis. We need to develop and implement trauma-informed anti-racist care to really support our racialized minorized patients and children. And that our anticipatory guidance, so anticipatory guidance is when we talk to counsel families and patients about things that they should be thinking about to promote their health, it has to include anti-racism as well. And so another book I read recently was during the pandemic was How to Be an Anti-Racist by Dr. Ibram Kendi. And one of the quotes, he had a lot of great quotes in the book, but one of the quotes that stuck with me was that racial inequities are due to racist policies, and that there are anti-racist policies that we need to advocate for, including inequitable education, regardless of zip code. So it really shouldn't matter the quality of education based on where we live. We need to close the racial discipline gap. It's necessary to remove the racial bias in the criminal justice system. We need to invest in disadvantaged neighborhoods, particularly those that have been historically disadvantaged for over generations. It's important to support affordable housing for everyone and anyone. I spoke about the importance of housing, the buying ability to buy a house, and the impact on generational wealth that even my family experienced, and the importance to ensure voting access to our minoritized population. It's also important for us to look at data within the healthcare system to identify any racial inequities that are happening. And this is a framework from Dr. Kamara Jones about infusing anti-racism work in the work we're doing and looking at the data and the health and healthcare outcomes. And so anti-racism is a work of actively identifying and eliminating racism at the individual, institutional, and structural levels, which is often perpetuated through unexamined organizational structures and norms. And with her framework, she states that if you see any racial differences in health or healthcare outcomes, it's not because of biological differences, it's because of racism. And you have to ask, how is that racism operating within the institution, the organization that you're working in? How is it operating at the institutional level or national level? How's it operating at the interpersonal level with our patients and families? And then we have to think about how do we organize and strategize for our stakeholders, for partners to act, to identify, to address the root causes of what's happening. So at UMass Memorial, during the pandemic, our CEO really wanted us to take a hard look at our data to identify any racial inequities with health outcomes. And so these are HEDIS measures from the ambulatory side, various outcomes, and this had never been done before, looking at various outcomes such as cancer screening rates, while childcare visits, flu vaccines, and this is the first time they looked at it by race. And what they found was that there was great differences. You look at this graph here, there are great differences with the well childcare visits, great racial differences with adherence with well childcare visits. And so we were tasked, this is started before I joined, but a few months later I joined the working group to think about how do we mitigate this? How do we address this inequity? And so first thing we did was we communicated with primary care providers and quality champions. We presented the goals of the project. We provided ongoing support to look at their own data. We expanded reporting. We added race, ethnicity, and language to EPIC reports. We leveraged the data to track progress and provided transparent reporting practices. So each practice saw how well or not well they were doing based on racial differences with well childcare adherence. And we try to provide tools and resources, including tip sheets, developing workflows to help providers leverage free transportation, for example, trying to work with practices to expand hours on the weekends and weeknights, as well as doing a lot of reminder calls and outreach to families to ensure that they would be aware of the well childcare visit appointments that was coming up. And so over time, this was a 1-year period we looked at, but it was pretty soon after a few months of kind of ramping up, where we began to see increased rates of well childcare visit adherence for our children of color and a decrease in disparities. And the disparity decreased by about a half or so from where we started for our Black and brown children compared to white children. We were fortunate and grateful to receive the first Bernard J. Tyson Healthcare Equity Award for this work from Kaiser Permanente and the Joint Commission. But we also wanted to learn more about some of the structural barriers to understand the structural barriers that our families were facing. So we did some qualitative interviews, and barriers such as transportation, language, work and other competing priorities, reaching young adult patients, which was difficult, cost of parking and employment availability had come up as true barriers for well childcare visits. And there are a couple of really powerful quotes that came out. There are many powerful quotes, but these are two that I pulled out. So regarding work and other competing priorities, one parent stated, "It's hard for me to leave the house and care for 4 children at once. Sometimes I don't have childcare for the other children when I go to an appointment for one child. Sometimes I bring 2 of my children with me. Sometimes I have to bring all 4." Another parent stated, "I do not have money for parking. In fact, sometimes I'm faced with a choice: attend the visit and pay for parking, or put food on the table that evening for my family and do not have my child see the doctor." I'll just say that we've been following the rates of well child care adherence for Black and Latino children, and we had actually pretty good sustainability for a while, but over the past few months, we've actually noted a widening gap and disparity, and so we're going to reconvene our groups and think about how do we do better, and how do we not only close the gaps, but how do we eliminate the gaps moving forward as well. All right, the third lesson from the pandemic, and also just from um, the social work, the social care work at large, is the importance of integrating effective, empathetic social care into the healthcare delivery system. And so again, for pediatrics, this is something we've been thinking about social determinants of health for generations. Again, because of the intrinsic link between social factors and our children's health and development. So Bright Futures are guidelines for health supervision visits. So for checkups, these are the guidelines that came out 30 years ago. And in it, in the Children's Health Charter, one of their guiding principles, they stated, again, 30 years ago, is that every child and adolescent deserves satisfactory housing, good nutrition, a quality education, an adequate family income, a supportive social network, and access to community resources. The Charter states unequivocally the explicit connection between a wide range of social determinants and the health of children and youth. In 2016, the American Academy of Pediatrics became the first professional organization to recommend screening for risk factors within social determinants of health during patient encounters, and subsequently Family Medicine and a few other professional organizations joined suit. And then in the backdrop of the pandemic, in the backdrop of the murder of George Floyd, um, many of the standard setting organizations really were having some really internal reflections about how do we emphasize health equity. And as part of it, they've been really enacting these health related social needs screening regulations. And so before that, many Medicaid ACOs, so accountable care organizations, and managed care organizations had S2H policies where they really incentivized screening for unmet social needs. Centers for Medicare and Medicaid last year mandated that for every adult inpatient hospitalization, that during that hospitalization, prior to discharge, health-related social needs screening occurs. And as part of the Joint Commission accreditation requirements, so the Joint Commission is for hospitals, they require that every hospital does some type of health-related social needs screening for some segment of the population that they take care of. And so I'm going to talk a little bit about the work that I've done in the space. The model we developed was called the We Care model. I like to say this is like my fellowship study, and 20 years later, I'm still working and talking about my fellowship study and the work that has generated. And I probably have more questions now than when I was a fellow as I started this work. And so we did a study in continuity clinic at Johns Hopkins, in pediatric clinic, in the Harry Lane Clinic there. And this model, We Care, so we basically have a screener. We ask families, do you have a risk, and then do you want help? And then we try to link to resource sheets from a resource book that lists community resources that are available and accessible. And we found that the We Care intervention increased the discussion and referral of adverse social determinants at low-income children's well childcare visits from about 10% to over 50%. We were able to get funding through the NIH, through a Career Development Award, to do a cluster randomized controlled trial to kind of build upon that work in 8 health centers in Boston. And I think ultimately they all became part of the OCHA network with EPIC. But this was pre-EPIC. And this was a cluster randomized controlled trial. What we found was that, not surprisingly, the children who were coming to these health centers had disproportionately had high needs. Over 90% of families had at least one unmet basic need. 2/3 of families had 2 or more needs, and almost 40% of families had 3 or more needs. When we looked at referrals, so after the visit, we asked families, did you get an information sheet or get a referral for one of these 6 needs around food, housing, employment, education, childcare, utilities? And we found that 70% of We Care families reported getting a referral after the visit, compared to 7% in the usual care or control group. We follow these children. We enroll children from birth to 6 months and follow them until they turned a year of age. And we found overall that 39% of children, or families, sorry, We Care families enrolled in a new resource, compared to 24% in the control group. And so we want to take this work one step further, and we wanted to test it under not just control conditions, so an efficacy study, but really under effectiveness study, change it to an effectiveness study under really real world conditions. And what we did here was, it's called a type 1 hybrid effectiveness implementation cluster randomized control trial. So we want to measure effectiveness. Does this program help improve child health care utilization outcomes, but also want to measure implementation as well. And we did this in 6 community health centers in Boston from 2015, and just for whatever reason with the timing of it, we ended exactly like a week before the pandemic started. So I can't blame the pandemic for some of the coming results I'm going to show you. And we followed low-income children through the EHR from birth to age 3. And the data was collected from the electronic health records. And by the end of the study, all the health centers in the study were on EPIC through OCHA. And many of them had switched to the OCHA EPIC about 2 to 3 years into the study. And what we found was that We Care families over this time period received significantly more resource referrals than control families at wild child care visits. It was about 43% to about 2%, just an odds ratio of over 4. But if you remember that under controlled conditions, it was 70% after that first visit. This is looking at the EHR for these children and families over 3 years. And so the rates were definitely lower. I did to do a shout out to, I think I saw Dr. Bill Adams on this OCHA Grand Rounds, and he was my go-to IT guy and helped me pre-EPIC to build this referral system, to print out resource sheets, and then help me to understand OCHA and EPIC and how to collect this data. So I just wanted to do a shout out to Bill. We had a patient navigator accessible across the 3 health centers. So she was there 1 day a week, at least 1 day a week at the 3 health centers. And over 20% of families were referred to the navigator in the We Care arm. So the usual care arm didn't have access to the navigator. And the majority of families, referred families, connected with that navigator. We looked at immunization adherence ratios and wild child care visit adherence ratios over those 3 years. And we found significant higher rates for immunization adherence ratios for the We Care children compared to the usual care children. We saw higher rates for wild child care visits as well, but it didn't achieve statistical significance. But one concept that we had really started thinking a lot about during the pandemic was this concept of double loss that some were reporting in other works through qualitative interviews and focus groups with low-income families. This concept of double loss, of parents disclosing a social need as one loss, so having the courage, the ability to share this need, to fight the shame that one has, to fight the fear that one has of sharing these needs with your pediatrician or the healthcare system. And the second loss of not getting help. So you disclose this and you don't get anything from the pediatrician. And parents didn't just want to talk it out, but they wanted the pediatrician to do something about it. And that was the whole impetus of We Care, that we would offer every family who said they wanted help a resource sheet, a referral, an opportunity to connect with a patient navigator if they wanted to. And so we looked at our data, and it wasn't it wasn't it was hard to look at, to be honest. We found that over 40% of parents experienced double loss in the first 3 years of life. That is, on the We Care screener, they said they wanted help and that they didn't get help. That was documented during those well child care visits. We found that Asian and Vietnamese speaking parents had higher odds for double loss. So almost 2/3 of Asian and or Vietnamese speaking parents experienced double loss. And in preliminary analysis, we found any parent who experienced double loss has significantly lower well childcare visits and immunization adherence ratios. So that there seems to potentially be some potential healthcare utilization detrimental harm for patients and families who experience double loss. So, our future work, we're really trying to be purposeful and intentional on how to address double loss, how to assess it in real time, and how to address it in real time as well. And so this kind of made us just think about, this rush to screen for social determinants of health, health-related social needs, and really with really good intentions, but is there some potential for us to do harm and to unfortunately increase the racial and socioeconomic inequities that persist in our society? And this was a commentary we wrote and came out a few months ago in JAMA. And we've been thinking about this a while, thinking about, are there some unintended consequences of screening, of SDOH screening, health-related social needs screening, that we just have to be mindful of? And so these are some guiding principles that we've listed both in this commentary and some additional ones we've listed in our most recent commentary. But the importance of screening needs to be family-centered in pediatrics. We need to integrate screening with referring and linkage to community-based resources. We had to minimize double loss. We had to do something about this. We have to emphasize shared decision-making. We have to realize our parents, our patients are the experts about the needs that they have, and we have to respect if they don't want to get help from us in the healthcare system. And many don't want to because of the harm that we've done to them, the mistrust that we've created, both with them, but also with their families over generations. We need to use a strength-based approach. We can't just focus on the risks that our patients and communities have, but also strengths that they bring as well. And that we shouldn't cherry pick and choose who should get screened. But if a practice does this, they should be agnostic about insurance or how a patient looks and screen for everyone. We've been kind of thinking that it's really important for us to co-design these social care programs with patients, staff, and community members really at the table to help us understand what we're doing wrong, how we can do better, and how can we build trust. And as healthcare systems, as we think about screening in general, we're only as good as the resources that are out there. And we need to use our collective voice to advocate for robust social safety net and equitable social and health policies. So just like in the healthcare system, we try to ensure the best medications that is proven by evidence, so evidence-based medicine. There are evidence-based policies that are out there, social policies and health policies that we know improve health, and we need to kind of get off the sidelines to advocate this as anchor institutions, as institutions that are valued and have some type of power within our local communities and beyond. All right, I know I'm running out of time, so I'm just go through a couple more. The pandemic showed us the importance to augment the social safety net. During the pandemic aid programs were huge, and they actually helped record a drop in poverty. So not only the child income tax credit, but also these pandemic aid programs around housing and food, particularly. This again, when we look at public spending on families and children, we see that as a percent of GDP, we see that the US is at the lowest compared to comparable countries. And we have evidence, both locally, nationally, internationally, that when you invest in social services, you have better health outcomes. And this is a paper that came out a few years ago showing that states who invested more in the social safety nets had better health outcomes for their populations. All right, number 5, the importance of prioritizing families' dignity. So this is another commentary that came up by Dr. Sandra Galea, who is the dean of the BU School of Public Health. The importance of elevating dignity as a goal for the health system in the future. So there's so much focus on patient satisfaction, but really the concept of dignity is something we should really be thinking about, which is a different construct. This is work from Dr. Deepak Palkshapa. So he looked at suburban families' experiences with food insecurity screening. And he found that overall they were comfortable discussing food insecurity with their pediatrician. However, parents expressed initial surprise at screening, followed by comfort discussing their unmet food needs. But parents told him and told his research study team that it's important for pediatricians to clarify that screening was to offer support and to acknowledge parents' feelings of shame that accompany food insecurity. So something that we have to be mindful of as we move forward. During the pandemic, I'm sure many of you remember the horrific story of Dr. Susan Moore. She was a Black physician who died of COVID-19. She felt she was not being listened to. Felt like she was being treated like a drug addict. And she was prematurely discharged and then readmitted and unfortunately passed away from COVID-19. So, really important for us to think about building the buffering, as one of my colleagues, Dr. Heather Forkey at UMass, talks about, and not suffering the suffering. The importance of us to building trauma-informed and resilience-informed care for our patients that's culturally appropriate and sensitive, engaging openly and honestly with families and really listening to them and trying to understand their experiences, their lived experiences. So I'm going to end here, and I know we all want to put COVID behind us, and the pandemic behind us. It has taught us so many important lessons regarding humanity, selflessness, trust, fear, mistrust, disinformation, anxiety. But it's also taught us really important lessons about advancing health equity, particularly child health equity, that I think we can build on moving forward. So thanks again for your time. And I really appreciate you listening to this talk. Thank you.
So, thank you, Dr. Garg, for that fantastic presentation, and thank you to everyone who attended today's session. Please be sure to follow UMass Chan Medical School on Instagram at UMass Chan and UMass Memorial Medical Center at UMass Memorial. And please be sure to follow Ochin on Instagram at Ochin Network and over on LinkedIn. In addition, head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to visit our Ochin YouTube channel to catch up on those past Grand Rounds presentations. And Ochin Grand Rounds will be back on March 21st with Dr. John Heintzman of Oregon Health and Science University as he presents on prevention and social determinants, disparities in utilization in Latino elders. Invitations to this presentation will be sent 2 weeks prior to the event, but if you're not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ochin.org. That's grandrounds, all one word, grandrounds@ochin.org. So from all of us at Ochin and Dr. Garg to all of you, have a wonderful rest of your day and stay healthy out there.